Thank you. All right, good morning. My name is Dr. Samah, and I'm really sorry that I'm late, but I was trying to find the theater and I can't find it. So thank you for being here really early. So I hope like it would worth your time. So today's lecture is about anti-metabolites and fluoroquinolones. And I think you've already had your series of lectures on antibiotics. So this will be the last lecture, I guess, on antibiotics. There will be antifungals that will be giving in a month's time. So without further ado, I'll go into the lecture since we're late. So the main learning objectives that today I'm going to be talking about is sulfonamides and quinolones. And what you need to know about the different types of sulfonamides that are used as antibacterial drugs or antibiotics, the mechanism of action, therapeutic mechanism of resistance, which I forgot to mention, and the side effects. The same thing for quinolones. The lectures are not available on Moodle now, but I will upload them after the lecture. So just a quick recap. As you know that antibiotics, they've been here quite a while since the first discovery by Alexander Fleming by pure serendipity. He had like an agar plate floating in his lab. And the second day when he came in the morning, he found that there's this penicillin fungus that actually inhibited the growth of bacteria. And from then, that's how we got the antibiotics, which were like a revolution at that time. People were actually managed to live and treating serious illnesses. And I remember, if you look at the history, when you used to work in London in the early 20s or early 30s, there would be signs saying penicillin treats gonorrhea. So it was like a big discovery then. But since then, penicillins or the beta-lactams, as we know them, they were the first class. They came out in the 1930s. But we also have the resistance of the drug that actually happened quicker, which is like just almost over 10 years later. And after that, we had the tetracyclines that were discovered, and then around the 1948. And then 10 years later, the first record of resistance occurred. And so on, then we had the microlids, and then from the microlids, we had the fluoroquinolones that we'll talk about today, and finally the carbamazepines. But since the discovery of carbamazepines until now, we don't have any new antibiotics. So it's quite challenging looking at the amount of drug resistance at the moment. And just for the record, don't want someone to email me, tell me, do I have to learn this for the exam? You don't. But I just thought it's something interesting to add rather than just having the lecture all information-based or academic-based. Okay, so types of antibiotics, I don't know how the previous lecturer talked about it, but the way we look at them as antibiotics are either bactericidals or bacteriostatics. Does anyone know the difference? Okay, so what's the bactericidal?
Bactericidal kills the bacteria.
Yeah.
So it eliminates the bacteriostatic. It breaks down the cell wall, or like it
stops the growth. Yeah, inhibits the growth of bacteria. Bactericidals because they interfere with the DNA and kills the bacteria. So the ones I'm talking about today are the quinolones, sulfonamides. I left trimethoprim on its own because it is on its own. But what you need to know that sulfonamides and trimethoprim, they are both bacteriostatic and bactericidals. Hence the link in the middle. I tried to be creative, but I don't think it worked. So sulfonamides, if they're used on alone, then they are bacteriostatic. But if we combine them with other drugs, or with other antibiotics, then they become bactericidal. The same thing for trimethoprim. It's a bacteriostatic in nature, but it becomes bactericidal if it's a drug that exists with the sulfonamides. Okay, so the very first thing to start with is I call sulfonamides are known as anti-metabolites. Does anyone know what that means? No, the term anti-metabolites, what is it? What does it mean?
I guess metabolism.
Sorry?
I guess metabolism
No,
acts on metabolic roots.
it does, but I'm talking about structure-wise.
Oh, it's similar to what's found at the John.
Yeah, it says there already. But it's an analog. It's a heavy term to understand. But we don't consider sulfonamides as antibiotics, although they are like looking at how they use. But first, they work in the same way as cancer drugs. So they interfere with they form an antagonist. So it's the normal how the normal drug the natural drugs work as a local key to later exert an action. So the analogs or those antimetabolites, they have the similar structure as the natural compounds found in our body or in the bacteria. So they work by binding to that site, and then since it's similar, but it doesn't have exactly the same structure, it inhibits the progress or the metabolic progress of that compound or that compound that works in the cell, basically. So sulfonamides, just a quick brief history, and you don't need to know about that as well. The first part, it was first came to existence by a scientist known as Dogma. He was a German scientist. And at that time, the sulfonamides, they came to existence, they were known as red dyes. So he tested them in animals who had streptococci infection. And he noticed that those animals, or those rats or mice, if I remember right, actually suppressed the bacterial infection. And later, what we knew later after his discovery, that those drug is called the protosinol. So it's a dye and it's inactive, but when it enters the body, it becomes active and it converts to sulfonamide. And hence, the sulfonamide actually the one that has the antibacterial effect. But Dogmak had a different idea. He thought that the dye itself, so this is the structure of sulfonamide, that he thought that the dye itself actually has the antibacterial effects. And that's why he actually, when his daughter was sick and she had a skin infection, he treated her with pronostanol. And although it cured the infection, but it left a permanent red stain on her skin, which was quite interesting. And less than 10 years later, he won the Nobel Prize for the first known antibacterial drug. But since the discovery of sulfonamide in the 70s, there were lots of resistance to sulfonamides. That's why even now, not many of them are actually in use. But as I mentioned before, sulfonamides, they're bacteriostatic alone, but in combined with other drugs, they're bactericidal. So some of them that are actually available is sulfamethoxazole, and that's actually was discovered in the 70s due to the increased resistance of the sulfonamides that we knew. So this was to increase to prevent them to potentiate the effect of sulfonamide drugs by having two antibacterials working together. And sulfasalazine, this is purely absorbed in the gastrointestinal. So that's why it's used as for bowel inflammation. It's a good drug since it is not absorbed in the stomach. And the other one is sulfadiazine, which I'm sure you've heard about in the PBL. It's used for burns, to treat burns. So what's the action of sulfonamide? The mechanism of action is, so to mention that first, that sulfonamides, they're broad spectrum antibiotics. And they work, as I said, by inhibiting a compound known as PABA, p-aminobenzoic acid. And this is a precursor that's essential in the synthesis of folic acid. Sorry. So sulfonamide works by inhibiting the hydroportrait synthase enzyme. So later interfere with the process of synthesis of folic acid, which is required for DNA and RNA synthesis, and hence inhibiting bacterial growth. And what you need to know here is that sulfonamide, because inhibits the dihydroportrait synthase, it's a teratogenic. So because it recruits the folic acid, so it's not given to women, which I'll talk about later, to pregnant women. So trimethylprim inhibits it's in the same pathway, but inhibits a different enzyme, which is dihydrofolate reductase. That later also involved it's important for the DNA synthesis. So here, as you can see, the anti-metabolites in action. So this is how the PABA looks like, and you can see that the similarity of the structure with the sulfonamides. So that's in essence, that's what an anti-metabolite means. Has a similar structure, but works as a competitive antagonist to inhibit the enzyme responsible for folic acid production. So from there, the mechanism of action is built in within the mechanism of action itself. So a mutation in the bacterial if there's a mutation in the enzyme, then this is a way of the bacteria to overcome the actions of the sulfonamides. Also, they decrease the uptake, so by changing the cell wall. So it could decrease the uptake of sulfonamide itself, or by increasing the production of PABA synthesis. So I try to keep this simple, no need to go into details, but that's what you need to know just clearly. The second thing is the sulfonamides as pharmacokinetics. So how do they work in the body? So they usually given orally, most of them. They're well absorbed and distributed in the body, and this is good as well as bad because also linked to their side effects. And they metabolize mainly by the liver. There is a risk of sensitization or allergic reaction that occurs usually the hives of urticaria that we see with sulfonamides. And the drugs usually they do enter the blood-brain, and so that's why we see the side effects, like for example headache or the placenta. So that's why if they cross the placenta, also there is the risk of teratogenicity. And by inflammatory exudate, does anyone know what that means? Yeah, so they reach the slide. So what are the adverse effects of sulfonamides? I'm talking about the serious effects that requires cessation of the therapy. It's usually if there's a development of hepatitis, hypersensitivity, as I said, urticaria or hives. This is usually looks like wells or drops found in the body. And there's also the crystal urea, which is the cloudy urine due to the precipitation of crystals in the urine. There's the other mild to moderate side effects like nausea, vomiting, headache, and mental depression, because as you said, like it crossed the blood-brain barrier, so we see those effects. Okay, so the next one, as I said, we'll talk about the trimethylprim, and mainly the one that you need to know about is the trimethylmethazole. So the second one, I said the trimethylprim was discovered later to combat the effects of bacterial resistance to sulfonamide. So as I said, the trimethylprim is a folate antagonist, but compared to the sulfonamide, it's a narrow spectrum antibiotics, and it antagonizes the folate, so later inhibiting the DNA. So as you see here, so in this same pathway, it inhibits the dihydrofolate reductase, which later leads to the inhibition of the DNA synthesis. So the second thing is the main uses of sulfonamide and trimethoprim is usually urinary tract infections. But the side effects of using trimethoprim is because it's antifolate, so there is a teratogenicity in the first trimester. So patients who usually don't give it to pregnant women because the drug works by needing the folic acids that from the humans as well as from the bacteria. So when you reduce the absorption, when they take the folic acid, then this later leads to spina bifida, birth and complications. So we don't give it in the first semester. And there is the blood hematological crisis. So patients can develop anemia. They can have reduced white blood cells. So especially we see that with the long term. And then hyperkalemia, which is high potassium levels. Yeah. So sulfonamides, as I said, the COX trimethylmethacrosol, that's the one that you need to know about because that's the one that mainly used which is the combination actually between trimethoprim and the sulfamethacrosol, and is used for prophylaxis treatment of pneumocystis gibberei pneumonia. Sorry, I can't pronounce bacterial pharmacology. Okay, so does anyone know what is it?
No, it's not yet taken.
Okay, so it's a fungal-like structure, but it's used. We only see it in immunocompromised patients, and it's especially in HIV patients. So we usually they get the drug to prevent. It's an opportunistic bacteria. I don't know if it's bacteria. They're saying it's bacteria, but it's not bacteria. It's a fungal-like structure. But don't take my words for it. Okay. So combined with there's another thing when we combine the sulfonamides with drug-resistant bacteria with so it's a drug that is used for antibacterial basically. Yeah. Okay. And toxoplasmosis. And in inflammatory bowel disease, we have the sulfonamide, as I said, it's used because it's purely absorbed in the gastrointestinal, so we don't we give it for that because it's quite effective. And the silver sulfadiazine, which is used for topically for infected burns. So let's do a quick question and stop me from talking. Sulfonamide drugs are selected for sensitive bacteria as compared to mammalian cells because yes, okay, that means we're listening because I didn't have that written down. Okay, yeah, so it's because mainly, as I said, folic acid is needed, so that's why it's a teratogenic and it's not given. Okay, so fluoroquinolones, quickly move on. It inhibits DNA synthesis. And since inhibits DNA synthesis, means it kills bacteria, so it's a bactericidal, and it's a broad spectrum antibiotics. We call them quinolones, fluoroquinolones, because most of them they have the fluorine group attached to them. So the main ones that we know, and you don't need to know all of them, but the most important one is ciprofloxacin because it's the main one that's actually used. And the uses are usually lower respiratory tract infections and urinary tract infections. So the mechanism of quinolones, it's quite complicated, but what you need to understand in its very simple form is that quinolones, they work by inhibiting two enzymes, two bacterial enzymes, topoisomerase 2 and topoisomerase 4. Those enzymes, they are involved in facilitating the bacterial DNA replication. So if you see, we are forming the double helix structure. So if you have the topoisomerase 2, so it produces the negative supercoat. So if you have a DNA around close, so to stabilize that, usually you form, there is a positive and negative sides to the DNA supercoil. So when the quinolones inhibits this process, which is making the DNA double helix negative, so change it from a positive to a negative structure, that later makes it look like this. So instead of having, a double helix that looks well structured, it introduces breaks into the DNA double helix, which makes it unstable and hence interfering later on with the DNA synthesis. Just need to understand that the double helix, that the quinolones inhibits topoisomerase 2 and 3 and 4. You don't need to go into the details of how it works, okay? Let's keep it simple. So when you're interfering with the supercoils of the DNA, that leads to the inhibition of DNA synthesis. Full stop. And as you can see, this is an example of ciprofloxacin because it's the main one. And you can see because it's fluoroquinolones because it has the fluorine ring. The mechanism of the structure is embedded within the mechanism of action itself. So the chromosome encoded mutation in the DNA gyrase. So if you introduce a mutation within the type of topoisomerase 2 and 4, then that's how the bacteria overcome the action of the antibacterial properties of the quinolones. And also, again, by altering the cell wall, so preventing the uptake of the fluoroquinolones in the first place. The fluoroquinolones, the antibacterial spectrum, they are, as I said, ciprofloxacin is the most typically used in the group. It's a broad spectrum antibiotic, effective against gram-positive and gram-negative bacteria and bacteriaceae, which is usually the aperic gram-negative bacillus. So, and the main thing is, if you remember what I mentioned earlier, the fluoroquinolones were actually discovered to combat increased bacterial resistance. So that's why fluoroquinolones are always used if a patient has a resistance to other types of antibiotics like penicillins, macrolides, what else? Aminoglycosides. So we use them as a difference. So that's why they're very effective against the monas and Neisseria gonorrhea, Campylobacter species. And usually, as we say that the fluoroquinolones, they're reserved for facultative and aerobic gram-negative bacilli and cocci. But we avoid them in methicillin-resistant Staphylococcus aureus, the infection, MRSA, because there is already a built-in innate resistance to it. So we avoid them in that case. So quinolones, they are absorbed well into the body, and since they accumulate in several tissues like the kidney, prostate, and lung, it's what we can say is that it's usually we use it to treat prostatitis, which is an important infection. It's not something that really known, but because it's absorbed in the prostate, we use it for infection in the prostate. And the lungs, because especially we use it for treatment like Pseudomonas, especially Pseudomonas aeruginosa infection in patients with cystic fibrosis. So, however, because it's absorbed or eliminated by the hepatic metabolism, which is the P450 enzymes, and partly by the renal, because usually if this enzyme involved, there is an issue with drug interaction. So if you, that's why we don't give it with antiacid. Does anyone know what antiacid is?
basically when I have a reflux, the acid reflux, it's an alkaline, so it basically neutralizes the acidity.
Yeah, basically. So you because because fluoroquinolones absorption is reduced when we give it antacid, we usually try to advise the patient to have it like 2 hours later or before taking quinolones, like leave a gap because of the interaction. Okay. So I did go through that. So as I said, Pseudomonas aeruginosa is the main type of respiratory infection, cystic fibrosis, and also the invasive external otitis, which is also caused by Pseudomonas aeruginosa. For urinary tract infection, because it's very effective against gram-negative bacteria and gastrointestinal tract, so trouble diarrhea, like E. coli, for example. So we usually give ciprofloxacin. And Neisseria gonorrhea, it's for sexually transmitted disease. There's also chronic negative bacillary osteomyelitis, and also the eradication of Salmonella typhi carriers. So the side effects of quinolones, usually we see seizures, but the main one that you need to have to understand is the tendon damage. So fluoroquinolones, they affect or cause tendinitis. So the joints that we have, they damage the tendons. So we try to be very careful when we give them to especially patients who are over 60. We try to be very cautious to give it to them. There's another issue, which is the QT prolongation. So it leads to ventricular arrhythmias. So if you know this is, I think you already had this before. So yeah, basically it's in the normal QT interval. This is the QRS and this is the T. So you can see here in arrhythmias, this is actually delayed increases. And arthropathy, which is also linked to the tendon damage. So that's why we don't give it to children, for example, because it damages the growing cartilage. And usually it's irreversible. We don't give it in pregnancy as well, or even adolescents. So I think we don't tend to give it to people who are 18 years or less. But there are other things that, but you don't need to know about this, is that people who have like mesenteric arthritis or people who have like any CNS problems, we don't also give them to. So that's why I said here, we did continue if there's a psychiatric or neurological and hypersensitivity reaction occur. We usually continue discontinue the drug. So the quinolones, since as we said, like example with ciprofloxacin, and it's metabolized by P450. Since it increased the risk of it was not given with unsafe. That's the first thing. But because it increased the risk of QT prolongation and causing arrhythmias, we don't give it with antipsychotics drug, macrolides, or antidepressants like SSRI. And also, yeah, the NSAIDs. Do you know what's the NSAID? Do you know an example of NSAID? Ibuprofen. So induces convulsions. So we usually don't try to give it with them, especially ibuprofen, because people take it a lot now. Okay, so let's do a question. Can you read the question? Yeah. So because it's contradicted in pregnancy, we don't give fluoroquinolones. So to summarize, sulfonamides, as I said, inhibits the incorporation of the PABA into the tetrahydrofolic acid. And trimethylprine prevents the reduction of so it works in the same pathway, but inhibits a different type of enzyme. And when we give the sulfonamide, they're effective because they potentiate the effects of antibacterial because they inhibit two enzymes in the same pathway. So it's important and it's great. And quinolones inhibits the DNA synthesis, as I said, keep it simple, inhibits topoisomerase 2 and 4. And the main causes of quinolones that we need to be aware of is that pentadiabetes. And at the end here, I just summarized the contraindications, just for you to help summarize everything. So I'll leave it for you to read it on your own time. But these are the main ones. Yeah. So as I mentioned, quinolones, you don't give it to under 18. Sulfonamides not for children at less than 2 years. And elderly, we don't give them, we try to be cautious with quinolones because it causes tendon, there is a risk of tendon rupture. Allergies, mainly quinolones and sulfonamides, both of them. Especially sulfonamides, there is an issue with skin reaction. Renal impairment, sulfonamides and caution. So we give them to patients who have like renal failure, but we have to be cautious and monitor them regularly. Same as for patients who have renal failure. We give them both sulfonamides and quinolones, but still caution needs to be taken in consideration. And for pregnancy, trimethoprim and quinolones, we usually avoid for those, but it's contraindicated in trimethoprim. Okay, so this is my references where I collected my lecture, and thank you so much for listening. The question, the MCQ question you mean? Okay, so what is it that you're not sure about?
Why my drugs is only working for the bacteria, not affect us?
Sorry?
The question is saying that the sulfonamides only affect bacteria.
Can you please keep it quiet because I'm trying to hear the question.
So sulfonamide, it only affects bacteria, it doesn't affect the human cell.
He's asking, does this
So I
question
don't
mean this
understand
way?
how the answer that's
Okay, I got it. Okay, so you're basically asking what the role of the folic acid, or isn't it?
no, I'm asking how does this answer? Like, I don't understand.
Like,
Okay, the sensitivity of bacteria. Okay, so sulfonamide, they don't work for all types of bacteria. So they work for bacteria that recruit and use the folic acid. So that's why we call them sensitive bacteria. But the issue is the sulfonamides, they take the folic acids from the human that we ingest. So it doesn't affect us, but it affects pregnant women, especially in the first trimester. So the folic acids in the bacteria that use folic acids in the process of DNA synthesis are the sensitive bacteria to sulfonamides. Does that answer your question, or I'm confusing you?
You don't use folic acid? No, I don't. Like, how does it take our folic acid?
Okay, that's a bit. So it's not, it doesn't take, but it's recruiting, or it's the absorption of the folic acid. So it's needed, it's a folate, so that we take it. It's needed for the bacteria, so the mammalian cells. We have the folic acid, isn't it? We have folic. So the folic acids that's in the bacteria, the bacteria that are sensitive to folic acids. So okay, your question is mainly asking the folic acid that in the bacteria, isn't it? But you're asking how we are in the human or in the mammalian we use it.
No, how are we, like, how does sulfonamide not work for us, but it works for the
Doctor, if you want, you can send
Because
you
the answer is that mammalian cells require folic acid, and how we don't have the reductive effect.
Yeah.
If you want, you can send you the email and yeah, because it's better.
Okay.
Jayman, listen, if you have more, send the email and the doctor will
I'll
reply.
send you an email. Maybe I'll explain it better. Or I'm really sorry if I'm not making any sense. I'm really sorry. So
What's your picture?
I'll send you a diagram that explains this, and then maybe it will help me because I probably can't communicate.
Thank you.